Hello, it's a pleasure to talk about ultrasound in trauma. Let's talk about some objectives of our class. Historically tracing how ultrasound evolution tends in trauma patients, propose a standard assessment consistent with the ATLS guidelines, identify the main dilemmas in the point of care ultrasound used in trauma, and a clinical case with decision-making trauma patients. Let's start talking about the name of this ultrasound in trauma. In 1996, the first appearance of the focused abdominal sonography for trauma. But this change in 3 years after international consensus standards in the teaching definitions, criteria, and applications of the new initial assessment with focused assessment sonography for trauma, think in something more extended, not only for the abdominal cavity, but all the primary surgery. In the past, it's used to lavage peritoneal diagnose. The evolution is 4 windows of the FAST, abdominal cavity and pericardial cavity. And nowadays, we need to use all the thoracic and abdominal and pericardial cavities. This name is extended FAST. Let's talk about a FAST. The primary surgery is needed to be performed. It's a mandatory propedeutic. It's the only way that you can look for shock, hypotension in these patients. It's 4 P's: pericardium, peripact, perisplenic, and pelvic cavity. The probe used is a convex beam mode only, response to the presence or absence of a free fluid in the abdominal cavity. The peripatic space, where the most free fluid accumulates, is the first. 250 ml are easily viewed. Remember that the negative exam did not exclude the hypothesis of blood in the cavity, the abdominal cavity. However, in some situations of hypotension in trauma, abdominal is probably the source of bleeding if the FAST is positive. Is replicable, had a good accuracy, and is a decision-make tool in trauma patients on the trauma bay. This paper finds the comparison about no free fluid on the FAST and a large amount of fluid on the FAST. And this patient had a therapeutic laparotomy. When you see no free fluid, no laparotomy, large amount of free fluid, large amount of laparotomy. The accuracy of the FAST, abdominal FAST, that like 95%. When you talk about the spaces at the abdominal cavity, when you have more than one location with a large amount of fluid, we have a high accuracy for abdominal trauma and blood at this cavity. Like more than 3 positive spots have a high accuracy for plus than 1 liter of fluid. Small fluid, just one location, no therapeutic laparotomy, no laparotomy. Large fluid, more than one location, more therapeutic laparotomy, only laparotomy. And you have a high accuracy interrelationship between fluid cavity and spaces cavity at the FAST. When you talk about the extended FAST, nowadays it's performed on the primary survey. It's looking for shock in these patients. Length windows, the probe was the convex or linear with B and M mode. The responsive one is the presence or absence of free fluid in the chest cavity or pneumothorax, hemothorax or pneumothorax. Is superior to the chest radiography, but soft tissue emphysema and atelectasis can difficult this kind of exam. When you talk about the chest X-ray and the trauma bay and ultrasound, the trauma bay, you need to understand this physiology of the chest X-ray. Remember, the trauma patient was a supine chest X-ray, and the X-ray plate was posterior. X-rays was anterior, and the most of the pneumothorax was anterior at the chest cavity. Of course, the conclusion is supine chest X-ray don't diagnose 50% of the pneumothorax in trauma patients. When I talk about the trauma patients in a trauma bay, the comparison head-to-head, chest X-ray and EFAST, EFAST was superior. In this paper, you can see that the clinical examination, chest X-ray and EFAST, all the whole population, the sensitivity of the EFAST is higher. Only in blunt trauma patients, the sensitivity of EFAST is higher. And in penetrating trauma patients too, the sensitivity of the EFAST is higher than chest X-ray or clinical examination for pneumothorax in the trauma bay. It's because of this, the diagnosis of pneumothorax in the trauma bay on trauma patients, EFAST has significantly greater sensitivity compared to chest X-ray and physical examination with significant statistical. In this meta-analysis, the sensitivity of ultrasound, EFAST, on the trauma bay was 88% and like 100 specifically. Chest X-ray on a half of sensibility. And in this last paper, recently published, we need an overall accuracy of 98%. And we can conclude that need to be present in a medical learning and the routines for the surgeons or trauma surgeons in the trauma bay, the extended fast. We need to diffuse this idea. We need to learn it fast for our students or our trauma surgeons. When you talk about extended fast in trauma, you can evolve for these 4 windows, for those windows. For the lung windows, we can check for sliding at the points similar like to blue protocol. Check the presence of intrathoracic fluid or air between the pleura. In conclusion, we need to check for hemothorax and pneumothorax. We can say anterior lung windows, looking for the pleural sliding or the lung point. In this video, the pleural sliding is absent. Diagnosis of pneumothorax. In this video, have the B lines and the pleural sliding. Diagnosis, no pneumothorax. When you look posterior at the axillary midline, the recess, we're seeking fluid on the chest cavity, fluid in chest cavity in trauma, hemothorax. And this you can see a large amount of fluid, and here the diaphragm. Diagnosis, hemothorax. Pericardic window is a substitute for the area must evaluating the longitudinal axis. The 4 chambers and part of the liver in the upper portion of the ultrasound field is the signaxon. Pay attention to the presence or absence of fluid around the cardiac silhouette. And the presence of this fluid in the cardiac silhouette, especially in large amounts with right ventricular diastolic collapse with hypocontractility, we can presume that cardiac tamponade may be present, okay? Like this, substitute for the area, longitudinal axis, see the 4 chambers of the heart and the liver. Free fluid accumulates here, between liver and right ventricle. Like this, 4 chambers, liver, normal exam. And that 4 chamber, liver, large amount of fluid with hypocontractility. May be presumed that was a cardiac tamponade in these patients. Peripatetic was in a mid-axillary line, 11-12 costal space, identifies the kidney, the liver, and the diaphragm. Names the Morrison pouch. The free fluids located at this Morrison pouch. Location of the probe, and here, liver, kidney, no free fluid. Liver, kidney with free fluid. Diaphragm is here. In this video, it's a normal kidney, liver, no free fluid. In this video, the kidney, liver, and the presence of the sharpened black line, free fluid at the abdomen. Diagnosis. Free fluid on the diagnosis is a fast positive. When we talk about the perisplenic window, posterior axillary line is the anatomic chapter. 10, 11 costal spaces identify the kidney, the spleen, and the diaphragm, the splenorenal recess. The kidney, the spleen, the diaphragm, without free fluid. That's an anatomic location, more posterior and superior than the Morrison's pouch. This picture, no free fluid. In that, with free fluid, sharpened black line here. In this video, you can see spleen, kidney, diaphragm here, lung, and the absence of the free fluid. When we talk about the pelvic, we need to do the exam 4 centimeters above this, the pelvic symphysis, the pubic symphysis. Identify the bladder, in particular pelvic organs like prostate or uterus. Here, female pelvis with the uterus without free fluid, and a male pelvis with the prostate without free fluid. Like it's easy to see the bladder because the bladder, when it's replaced of urine, was hypoechoic. It's black here, like a free fluid. That's the location, atomic location. Here, a longitudinal axis without free fluid. And that, another image, without free fluids. Here the bladder, the normal exam, and here the bladder and a free fluid of the pelvic space. Look here. That's a fast positive. Heads up. Pay attention to these points. It's not possible to differentiate which type of fluid we have in the cavity. It's urine, blood, acidic fluid, or bile. Negative fast does not exclude abdominal injury. However, it makes less likely that the source of the shock or hemorrhage is the abdomen. Visualization of the suprahepatic window is best seen with a full bladder. That is, choose to perform the FACS exam before inserting a urinary catheter. Subcutaneous emphysema and obesity make it difficult to perform the extended fast exam. Be careful with the interpretation of atelectasis in the E-fast. Let's talk about two cases. Case 1, motor vehicle collision, high energy, stable at the trauma bay, Glasgow Coma score 50. That was the first fast at the primary surgery. The patient had this blunt abdominal trauma with this hematoma in the anterior abdomen. You can see the negative exam. Here, the liver, the kidney, and negative fast. Of course, fast is replicable. After 20 minutes, the primary survey reassessment of this patient becomes stable, and that is the new fast with a large amount of free fluid. We take a trauma laparotomy and small bowel injury, grade 5. Remember the importance. The fast exam is replicable and decision-making importance. Another case, a blunt abdominal trauma and pelvic trauma, and stable at the trauma bay. It's a large amount of microperfusion, base excess, negative 10. We started blood transfusion, and whoa, who is first? Laparotomy, pelvic fixation. We performed a fast exam with decision make. And if the patient has no free fluid at the abdomen, like this, no free fluid, and no free fluid, we start with a pelvic fixation with the orthopedics before pelvic packing with the surgeon. But if the patient has this fast,
beleza,
with free fluid, we start with a laparotomy before pelvic fixation. You understand that? No free abdominal fluid, start with the pelvic. With free fluid at the abdomen, start with the laparotomy. And we can conclude fast is an important tool to decision make for the trauma surgeon in the primary survey in the trauma bay for trauma patients with unstable hemodynamics or stable hemodynamics. Thank you.